Thank you very much, Mr. Chairman and Shri and SCTS for inviting me to speak on this topic. Yet again, this is the third time I think I've been invited very kindly to speak on this topic. I was just sitting there and listening to Mike and all of you in the discussions earlier. And the first time that I spoke at this meeting on this topic, I was challenged by one of your colleague thoracic surgeons saying it doesn't make physiological sense. And a few years down the line, I can see that many thoracic surgeons are actually placing the valves and doing all the bronchoscopic interventions, so clearly probably makes some physiological sense. And probably in the years to come, you won't need an intervention of a pulmonologist or a chest physician to come and speak on this topic. All of you seem to be really keen on it. My job, I was told, is to convince you that you may not need surgery in due course for emphysema because of endobronchial therapies. And it looks like most of you are already convinced that job is made easier. And secondly, Mike has given a very thorough introduction, so I'll skip through some of the slides that I have prepared. I don't have any commercial interest, although I've been involved in some studies of the valves, early studies of the valves. Mike has already covered the pros and cons of surgery to some extent and mentioned the NET trial. I just want to highlight one point, that even in the NET trial, the exercise capacity improvement and the quality of life improvement compared to the control arm was not massive, and it was restricted to this group of patients with upper lobe and low exercise tolerance. So much so that a couple of articles written by surgeons highlighted that the death rate of surgery is about, death rate of surgery is about 6 to 10% nationwide, and it is one of the highest risk procedures in practice. And also they mentioned that the 90-day mortality is 4%, in-hospital stay was 13.5 days, persistent air leak was the main contributor to the in-hospital stay. I don't know whether you see this in your practice now, pneumonia, etc. All this led to the birth of bronchoscopic lung volume reduction, and this is the first paper from the Brompton Tudor-Termine group, and in N equals 8 study made it into the Lancet, which was groundbreaking. And of the 8 patients who were taken up for this valve placement, 5 of them were thought not to be fit for surgery or for anesthesia, and 3 actually refused to undergo the operation. But by default, this led to a number of studies in the use of valves and other techniques, which I'm going to cover over the next few minutes. I've divided the techniques into 2, reversible techniques, and the other bit is bronchoscopic treatment of lung parenchyma. So let's cover these in the next few minutes. First of all, the reversible techniques. The most commonly used valve is what you see up here. This is the Zephyr valve, which is a one-way valve, which is what all of you. In fact, how many of you are placing valves? Thoracic surgeons, by the way. A fair number. This is a pretty straightforward procedure. That's why we physicians do them, besides surgeons. And it involves some assessment, which I'll go through in a minute, through the flexible bronchoscope. Most of our procedures are done under sedation, although I tend to do it in a deep sedation list with an anesthetist, giving propofol, but can be done even under moderate sedation. The first major trial that was carried out, and there are a number of trials since, the first major trial was the Vent trial. There's a US Vent trial and a Euro Vent trial. It showed that there was some modest improvement in these patients with emphysema with regard to dyspnea and quality of life, and with regard to 6-minute walk test, and some improvement in lung function. But the adverse events that were mentioned were pneumonia and hemoptysis and pneumothorax. I mention this here because in the years that followed and the studies that followed, pneumothorax incidence progressively went up. And why is that? Because we got better and better at achieving target lung volume reduction. It became evident that you can do a great deal of good for these patients only if you achieve proper lobar atelectasis. And how do we do this? This is what Mike has outlined very nicely. In the MDT, we discuss how and likely that we are going to achieve target lung volume reduction. This is by the use of CT planning to ensure that the fissure is intact, to exclude other potential reasons for turning down the patient. And then during bronchoscopy, we do a Chartis assessment. A specific balloon catheter is passed through the bronchoscope. Using this console, we then view the flow, the expiratory flow, which is seen here. Oops. The expiratory flow and the inspiratory pressure and the airway resistance, and that tells us whether there is collateral ventilation or not. Daniel Gompelman's study from Heidelberg showed that using the Chartis study alone, you are likely to be right 75% of the time. But if you combine with HRCT planning and better imaging that is used now, which is something like this is called the VIDA scanning, or more recently, a web-based StratX platform where you upload the CT scan and then it generates data including the presence or absence of an intact fissure and predicts the likelihood of collateral ventilation or absence of it. With all these techniques, a number of studies have been done in the last few years. Mike mentioned about the NICE review and NICE guidelines from 2013. Since then, there have been a few extremely well-designed studies. This one from the Brompton, the Believer Hi-Fi study, which is a double-blind sham-control RCT, which demonstrated that there is safety and efficacy of endobronchial valves in patients selected purely with HRCT. So that was the Believer Hi-Fi study. Then you had the study which is the Stelvio study, which used, it's an RCT again. This is from the Netherlands, Dirk-Jan Sliebos's group, showing that if you use the Chartis alone, you can potentially improve the likelihood of achieving target lobar atelectasis, volume reduction in atelectasis. Most recently, Arshang Walipur and team from Austria have done an excellent study called the IMPACT study, but this was unique in that this picked up even homogeneous emphysema. You touched upon, you asked about homogeneous emphysema, and using CT and using Chartis to select patients even within the homogeneous emphysema group, which is a large group. Mike showed that 28% in your study were homogeneous, and therefore you could not do the lung volume reduction. This IMPACT study, I don't have time to go through in detail, but this clearly puts us in a different path with regard to the use of valves. Trying to summarize all these studies in one slide, you will see that majority of these studies have shown, these studies certainly have shown, that there is an improvement in lung function, improvement in 6-minute walk test, and a dramatic improvement in St. George's Respiratory Questionnaire. The quality of life improvement is quite marked. So these days, when we talk to patients when they come to the emphysema clinic for assessment, we present all this data, this up-to-date data, and discuss with them the benefits versus risks. No doubt, many of these patients come and tell me that they have watched something on one show, and therefore they want to undergo a coil procedure as opposed to valves. They bring the Daily Mail articles, the cutouts, and say, this shows that valves are better, so I prefer valves. But we, from our side, we try to present all this literature. There is one other valve which is not used extensively in the UK, but in Europe certainly it is used. And this is the spiration valve. This is a study that I was involved about 10 years ago. And this valve, spiration valve, is a very effective valve. It's been marketed by Olympus now. But they do not make a device for collateral ventilation assessment. They're looking at more about CT selection for these patients. The European study which we were involved with was a sham control study, and again it showed some improvement in CT changes and in SGRQ, but there was no lung function response. So that's about reversible techniques. In the next few minutes, I'm going to cover irreversible techniques or treatment of lung parenchyma. One of the early studies which was done was with heated water vapor. Even hot water has been used, but this was heated water vapor, and it did seem to produce quite marked inflammation, occlusion, and atelectasis. The only downside was that these patients developed severe pneumonia and very severe exacerbations, And in fact, there were a couple of mortality incidents immediately after the procedure, and therefore this technique was suspended temporarily, but is being studied again in a more selective patient subgroup in a more controlled fashion. The similar story was what panned out with the biological lung volume reduction using Aeroseal or hydrogen fibrin thrombin mixture. And there again, there was very good improvement of lung function, but extremely severe side effects with pneumonias and infective exacerbations. And that warrants further study, and I'm aware of some studies that are taking place. What has come more recently, but is slightly more evidence-based, is the use of coils. How many of you have been involved with the placement of coils? It's 1, 2, 3. Okay. So surgeons have entered the coil arena as well, which is great to see. The principle with the coils is that it simply improves elastic recoil, thereby restoring the radial suspension of the airways, reducing airway resistance, reducing air trapping, and thus improving exercise performance in dyspnea. That's the principle, that's the hypothesis. And these coils need to be placed under fluoroscopy guidance. This is a procedure being performed real time. This video shows that it's being done through the rigid bronchoscope and through that the flexible bronchoscope. In our center, we do it under general anesthesia with an ET tube, 8.5 ET tube in place, and under fluoroscopy guidance. This is an expensive procedure because each coil costs on paper about £1,000, and you end up placing, last week placed some coils in a patient, and it ended up with 13 coils in the left lower lobe. So it's quite expensive, but we are doing it as a part of a European registry, research registry. The first randomized trial which was done was from the Brompton. Pallav Shah's group randomized patients to coils or best supportive care, and they showed that there was an improvement in SGRQ and in 6-minute walking distance, and that seemed to suggest that the coils are effective as well as safe. A larger, more recent study, 2 studies actually have been published. I'll mention one of them, the RENEW study in JAMA. It's a multi-center study. Majority of the centers were in the US and 5 in Europe. And this study with the coils has given us some further information about the efficacy of coils, relative safety of coils, but the most important bit of information that we've gained from this study is that the higher the residual volume, and in some of the algorithms they've used, and net trial use residual volume greater than 150%. We went up to 175% in the next study, greater than 200%, and in this, the subgroup analysis shows that if the residual volume is greater than 225%, those patients did better. And this study included both heterogeneous and homogeneous emphysema. In our algorithm at Preston, we use residual volume greater than 200%. So based on all this information, Pallav and Felix from Heidelberg wrote a very nice article in Thorax trying to suggest an algorithm which has been modified subsequently, but gives you an idea of way things are evolving in this field. FEV1 less than 45%, residual volume greater than 200%, optimal medical treatment including pulmonary rehabilitation, HRCT, we put in quantitative perfusion scan on top of that. We also do an echocardiogram, and then have a discussion in the MDT, which is then divided into heterogeneous or homogeneous. Depending upon the tissue destruction, we always ask the surgeons first because we prefer, as it stands, as Mike mentioned in the GOLD guidelines also, we prefer to explore the surgical approach first. Otherwise, we think about valves or coils, and then comes the collateral ventilation assessment. What I'm trying to say is any procedure for emphysema should be performed only with a systematic evaluation in an MDT setting, with the thoracic surgeon being present, exploring also the possibility of entering these patients into research trials. So in conclusion, interventional pulmonology, as I put it, I know it's thoracic surgical interventional pulmonology as well, in emphysema is exciting, it's evolving, it's no doubt expensive, Evidence base for endobronchial therapies in emphysema is growing. In the last 3 years, there have been 4 major randomized controlled trials. Systematic assessment is crucial. The valves and coils seem promising, but preferably as it stands should be done in larger volume centers, considering research or at least a registry and very clear audit and governance protocols. Emphysema MDT introduction has led to not an increase in the number of interventional pulmonology procedures. What we have seen is an increase in LVRS, which is for the benefit of the patient. There has been a very good cost analysis done in the Revelance trial, which was published from France recently. I've not had a chance to go through, which shows that these techniques are indeed extremely expensive. Complications should not be underestimated, because with the valves, initially we saw about 5% incidence of pneumothorax. With better technique and better patient selection, that incidence has gone up to over 20% pneumothorax in many centers. And I think surgical and bronchoscopic techniques are complementary. That's why we believe in a full-fledged multi-professional effort. And I always show my surgical colleagues, one of them who's there, that we need their help as well sometimes. Thank you very much for your attention.